do these exercises, you don't have to check airway. No, it's already established that's what's going to happen. So basically what we're going to do, penman, personal protection, make sure my seat is safe, kid's bleeding. I'm going to go ahead, I'm going to get a 4x4, and I'm going to hold pressure. Hold pressure, hold pressure, hold pressure. After a few minutes, I'm going to check to see if it's, stops bleeding. So I'll just let go of this. I see blood still coming out. All right, it's not working. So I'm going to get my tourniquet. I'm going to put my tourniquet on. I'm going to put it 2 inches above the wound, but not on the joint. So 2 inches above the wound, but not on the joint. Then I'm going to go ahead and tighten it. Make sure it's nice and snug with the Velcro. Then I'm going to go ahead and twist it. And I'm going to twist it and twist it and twist it until the bleeding stops. Once the bleeding stops, I'm going to secure this, and I'm going to write the time. Write the time on the tourniquet or on his forehead. Once that's done, I noticed that he's pale, cool, diaphoretic. So I understand that he's going in shock. So I'm going to lay him supine, lay him flat. I'm going to go ahead and cover him with the blanket to make sure he's warm. I'm going to give him 15 liters of oxygen by mask. Turn the 15 liters on. Fill up the reservoir bag. Give him oxygen and immediate transport to the hospital. That's it. All right, so that's for him and a cut when he's bleeding. So now we're going to go over what to do for him if he has a broken leg. So let's say his leg is broken, tib fib fracture. First thing I'm going to do, gloves, PPEs, make sure my scene is safe. Then I'm going to come up to him, and I am going to have my partner or somebody else hold manual stabilization. Just keep the weight off of his leg. Once they do that, I'm going to come and I'm going to check for CMS. Check for cap refill. Ask him to wiggle his toes. Ask him if he knows which finger I'm touching. Also take a pedal pulse. Then I'm going to get a splint that's going to fit him. So I'm going to make sure the splint fits him. I'm going to want to make sure I immobilize the joint below and the joint above, since it's a break on a bone. If it was a break on a joint, I'm going to make sure that I stabilize the bone above and the bone below. But this one looks like it's good. If I need to, I'll pack it up just to make sure that I fill in any voids. And then I'm going to secure the splint. I'm going to make sure, if I can, not to put any type of tape or anything to cover the injury itself. If I need to, if I can, I could go ahead and put an ice pack, as long as it's not too painful, to help with swelling and with pain. And then once this is all back, I'm going to go ahead and check for a pedal pulse again. Check his cap refill. Can you wiggle your toes? Do you know what toe I'm touching? And you're going to transport him to the hospital. So splint before, check CMS before and after splinting. Questions?
Is the ice pack a pretty big deal?
Huh?
The ice pack's like a big...
No, you could say, you could use it. If you don't say it, not a big deal. You don't fail. Right. Cut. Cut. No, that's a cut. Set up the oxygen tank. If I can remember, and if you guys remind me, I will tell the instructors that day to have you guys set these up first. So if you guys remind me on Saturday, just tell me, hey, can you remember to tell those guys if we could set up the oxygen first? Because sometimes it gets confusing as when do I do it, when do I not do it. So the first thing I'm going to do is I'm going to go ahead and get the tank. I'm going to inspect the tank, make sure that there's no cracks or dents or anything on it. I'm going to make sure it's oxygen. I'll know it's oxygen because it has a green color on it. Then I'm going to get the regular. I'm going to inspect it. I'm going to make sure there's an O-ring inside of it. Make sure that this is all functional. Then what I'm going to do is I'm going to crack tank open. Let the debris come out. Then I'm going to go ahead and I'm going to assemble the regulator. I'm going to make sure I slide it down, make sure those two prongs go right into the holes, and then I'm going to go in and tighten. Hand tighten is probably good enough. Then I'm going to turn the oxygen on. I'm going to check to make sure that I have enough pressure. I'm going to make sure that there's no leaks. I'm going to listen to it to make sure that there's no leaks. And once I know all that's going, then my oxygen tank is ready to go. Let's setting up an oxygen tank.
It says you have to attach the non-rebreather mask to the correct.
So that'll be so we'll do that when we're gonna do oxygen administration. I just wanted to set this up so it was set up for the rest of them. So that's why I'm gonna tell those guys to hopefully have you set this up first, not to necessarily put oxygen on, but just to have it set up so you could do the other exercises, and then we'll do the oxygen administration after. So this is ready to go. All right. So now I'm gonna do airway on an apneic patient or bag valve mask on an apneic patient. So I come up to a patient, and I'm gonna go ahead, I'm gonna open up his airway. At the same time, I'm gonna check for a pulse, and I'm gonna check to make sure he's breathing. I'm gonna look for rise and fall of the chest. So let's say I feel a pulse, but I do not see rise and fall of the chest. So I'm gonna go ahead and I'm gonna open up his airway. If it was a trauma, I do a jaw thrust. If not, I'm gonna do a head tilt chin lift. As I do the head tilt chin lift, I look inside, and I actually see some stuff that I have to suction out. So I'm gonna go ahead and get my suction, get my tubing, make sure everything's all connected. I'm gonna turn the suction on. I'm gonna feel for some, make sure I have a suction. Then what I'm gonna do is I can either measure the oxygen tank, and the suction device, and only go as far as from the ear to the edge of the mouth, or I only go in as far as I can see without losing sight of the tip. So I'm gonna stop the suction from going, when I'm going in, suction only as far as I can see, or the measurement. Then I'm gonna start to suction in a circular motion on the way out for no more than 15 seconds. Once they're all suctioned out, I'm gonna go ahead and open up his airway again and check for a pulse for no more than 10 seconds, just to make sure he hasn't lost his pulse. So he still has his pulse. I'm gonna insert an OPA. I'm gonna get the OPA out. I'm gonna measure for the size from the corner of the ear to the edge of the mouth. This one looks like it's good. I'm gonna insert it upside down so I do not, so the tip touches the roof of the mouth as to not push down on the tongue. Halfway in, I'll spin it around. If there's a gag reflex, I'll take it out. If there's no gag reflex, I'll go ahead and put it in. Once it's in, I'm gonna get my bag valve mask. I'm gonna start without any oxygen attachment because I don't know how long he's been down for. I'm gonna do my CE grip, and I'm gonna go ahead and I'm gonna ventilate the patient one breath every 5 to 6 seconds. I'll be looking for equal rise and fall of the chest to make sure I'm getting adequate breaths in. After about 5 or 6 times of giving them one breath every 5 to 6 seconds, I'll go ahead and I will attach this to oxygen. I don't see the tubing for it. I want to do this within 30 seconds. So I'll connect this to this. I will connect this to this. I will turn the oxygen on, making sure I go up to 15 liters per minute. Have the reservoir bag fill up. And then I will go ahead and I will start ventilating the patient again. One breath every 5 to 6 seconds. Looking for equal rise and fall of the chest. So that's how I've been doing this for a few minutes, and then all of a sudden the patient starts to move and starts to cough. I'll remove the I'll remove the OPA, and then I will go ahead and attach a non-rebreather mask. So I will disconnect the oxygen tank from the BVM. I will attach the oxygen mask, making sure I have at least 10 liters per minute, but 10 to 15 liters per minute. I'll fill up the reservoir bag. The reservoir bag fill up, and then I will attach the oxygen mask snugly to the patient's face. Now I failed these exercises. Anybody know why I failed these exercises?
You didn't check his pulse. No
I
PPE.
never put my PPEs on. So always remember to put PPEs on for every one of these exercises. Any questions on these? That was oxygen administration. That was bag valve mask, suctioning, OPA. And man starts for PPEs. Now, you guys want me to remember this? PPEs. Ensure the scene safety. Number of patients, one patient. Mechanism of injury, I don't know. Additional resources, let's get some more people.
It was a bad time for Jerry to be
And
recording.
for C-spine. So I don't know how he got to the ground. So partner, go ahead and hold C-spine. So let's have one of you guys who's not recording hold C-spine. Hold C-spine. So he's gonna hold C-spine. Then I'm gonna come up to the patient and I'm gonna say, sir, wake up. At the same time, I could be checking for a pulse. So he has a pulse, he's not waking up. So then I'm gonna go ahead and check my AFU. AFU stands for alert and oriented, or alert is he verbal stimuli, painful stimuli, or he's unconscious or unresponsive. So I'm gonna shake him. If he opens up his eyes, I'm gonna say, sir, what's your name? Where are you at? What day of the week is it? And what's going on? Person, time, place, and event. If he answers all 4 of those, he's alert and already times 4. If he answers 3, he's alert and times 3. 2, he's alert and already times 2. Or answers 1 of them, he's alert and times oriented times 1. And if he doesn't answer any of those questions, he's alert and oriented times 0. If he doesn't answer my questions, I'm going to say, sir, sir, sir. If he opens up his eyes and starts tracking me and he's talking to me and maybe follows my commands, but he isn't talking to me, that means he's alert to verbal stimuli. If I call him and he doesn't wake up, and I could pinch him, I could do a sternal rub. If he opens up his eyes and follows commands or moves or does any type of thing, that means he's responsive to pain. And if he shake and shout, do all that kind of stuff and everything, and he's still not responsive, then he's unconscious or unresponsive. Yes?
Could you explain the outfit and stuff like that?
I would, because as I said, when you're doing this, the more you tell us, the more we know you know. You make a little mistake here and there, you know, it's not going to cost you as much as opposed to us trying to figure out, do they really know what they're talking about, or they just memorize that page? You don't have to, but if you know it, you might as well just say it. It's not going to kill you. So I check my app was all there. Then I'm going to check and assess his ABCs, airway, breathing, circulation. I'm going to look at him, and if he's talking to me and he's able to talk, then I know he has a patent airway. If not, I will go ahead and do a jaw thrust to go and open up his airway to make sure he has an airway. I'm going to check his breathing. I'm going to look for rise and fall of the chest. If he's able to talk to me, I'm going to check to see if he's talking in complete sentences. Also, if I need to, I can go ahead and listen for lung sounds. And then I am going to check for his C circulation, so I can check for a pulse. I can also look at his color, look at his skin signs, see if he's sweaty or anything like that to figure out whether he has good circulation. I can even check cap refill to see how that's working. So if his ABCs are all there, I will go ahead and stay and play and everything's good. But if any of his ABCs are compromised, he's missing it, losing it, not good, I will go ahead and load and go. But in this situation, we'll say that everything is okay, so we'll go ahead and stay and play. So then I'm gonna go ahead and let's say he's talking to me, so I can go ahead and ask him for history, allergies, meds. I can go in and ask him if he has any pain, and if he does have any pain, I could go ahead and do an OPQRST real quick. But eventually I'm gonna go ahead and I'm gonna start my head to toe assessment. So starting with the head, I'm gonna go ahead and look for DCAP BTLS. DCAP BTLS stands for deformities, contusions, abrasions, lacerations, punctures, burns, swelling, tenderness, whatever I'll say next. So I'm gonna go ahead and I'm gonna start with the head. I'll go ahead and palpate his head, feel the back of his head, looking for DCAP BTLS. I'll look at my gloves to see if there's any blood or anything like that. If everything's good, then I'll go ahead and go to the face. I'll go ahead and put feel his head to make sure it's stable. His cheekbones, maybe his jaw. Move his nose a little bit, make sure that's all stable. Then I'm gonna check his ears. I'll check his ears for any fluid coming out of his ears, blood or cerebral spinal fluid. Then once I'm done with that, I'm gonna check his pupils. I'll go ahead and get a pen light, check his pupils to make sure that they're equal and reactive to light. Note if they're not, figure out what's going on with them. Also, I could check for raccoon eyes, which could show a sign of a spinal or neck injury. I'll go ahead and check his for raccoon eyes, which is bruising around the eyes. Then I'm gonna check his nose. Again, the stability of his nose. I'll also look inside his nose to look if there's any obstruction, look if there's any powder, any signs of any type of drugs, maybe some paint. I go look to see if there's any blood. I also want to look for any singed nasal hairs to make sure you didn't inhale any flames that could actually swell up his airway. All that's clear. I'm going to go down to his mouth. I'm going to check his mouth. I'm going to look in his mouth for any obstructions. I'm going to look for any broken teeth. I'm going to look for any blood. I'm going to look for any type of oral trauma in his mouth. Once I clear his mouth, then I'm going to inspect the neck. I'm going to start with the back, and I'm going to check his neck, go up and down his neck, check looking for any type of step off. Also look at the front of his neck, looking to see if there's any DCAP BTLS along with any type of a tracheal deviation or any JVD. Neck is clear, then I'm going to go down to the chest. I'll expose the chest if I can. I'm going to look for the stability of the chest. Push down, push in, see how the stability of the chest is. If I have my stethoscope, I'll go ahead and listen for lung sounds. I'm also looking for DCAP BTLS, contusions, abrasions, lacerations, punctures, any type of trauma or anything like that to the chest. Once I clear the chest, I'm going to go down to the abdomen. I'm going to palpate all 4 quadrants. I'm going to be checking for Dr. Germ, which any distension, which is any swelling. I'm going to check for rigidity, see how hard it is. I'm going to check for any guarding and see if they're guarding. I'm going to check for ecchymosis, which would be a change in color, discoloration of color in the abdomen. I'm gonna check for rebounding pain. I'm gonna check to see if I hit him over here, and maybe he has pain in another part of the body if I push down. And I'm gonna also look for any type of masses, any type of pulsating masses or anything like that. Once I'm done with the abdomen, I'm gonna go down to his waist, pelvic area. I can push down and push in, check for the stability of it. While I'm down here, I'm also gonna check the genitalia. I'm gonna look for any priapism, which is a male erection in a male that could show signs of possible spinal injury. I'm also going to look for any incontinence to see if he's urinated or defecated on himself. Once I go down, I'm going to inspect each one of his extremities, doing opposite pressure. I'll check his knee for stability. Then I'll go opposite pressure again. Opposite pressure on his thigh or femur. Check his kneecap. Then go back opposite pressure. I'll go on his feet. If he's able to talk, I'll go ahead and have him push down like a gas pedal, have him push up, toes to his nose. I could check for a pulse on both. I'll check for a cap refill. I can have him wiggle his toes. I can also ask him which toe I'm touching. Then I'm gonna go up to his upper extremities, start with his arms, go up in his arm, check opposite pressure, check his elbow, opposite pressure. Then I'll do the same thing, opposite pressure, opposite pressure, opposite pressure. Then I'll go ahead and grab both of his hands. I'll check for pulses on both wrists simultaneously. Also ask him to squeeze, if he could squeeze. I'll check his cap refill, ask him to wiggle his fingers, or ask him to which finger I'm touching. Then we're gonna go ahead and check the back. And actually before I do that, I'm gonna go ahead and put a C-collar on. Now that I know he has good motor functions, this is a splint, so I gotta make sure I check my CMS before. So I can measure it by measuring the side of his neck, and then also adjusting this to make the size of the C-collar. I'm gonna slide it from behind, put it around his neck. Oh, keep holding on. Nope, keep holding on. Put it around his neck. That's now on him. C-collar on him. Keep holding C-spine. Then we're gonna go ahead and inspect the neck. I'm sorry, the back. So we'll get the backboard. So lay the backboard next to him. If I had extra people to help, I would have extra people to help. One person on his elbow, one person on his hip, one person on his ribs, one person on his knees. And then on the heads count, we're gonna go ahead and roll him. So go ahead and count head.
3, 2, 1.
Roll him over. Once he's on his side, I'm gonna go in and inspect his back. I'm gonna check for decap details, deformities, contusions, abrasions, lacerations, punctures, burns, swelling, tenderness, all the way from the top all the way back down. Once I know that's clear, we'll go ahead and roll him back onto the backboard. We'll lay the backboard at a 45-degree angle. At the heads count, we're gonna go ahead and roll him back down.
3, 2, 1.
Roll him down. Now he's not completely on the backboard, so what we're going to do is we're gonna perform the Z motion. The heads count, we're gonna go down, and then we're gonna go back up.
1, 2, 3.
Down,
1, 2, 3.
up, boom. So now he's centered. So before I secure his head, I'm gonna make sure that I secure his torso, the biggest part of his body first. So I could go ahead and secure his torso. So once his torso is secured, I can now secure his head. So I'll put one head block on one side, put the other head block on the other side. You can go ahead and let go. So his head is now secured. So now I'm gonna ask him to go ahead and squeeze my fingers again. Does he know which fingers I'm touching? Can he wiggle his fingers? Then I'm gonna go down to his feet, check for pulses, tell him to push down, tell him to push up, which toe am I touching, wiggle, all that kind of stuff. Now once he's done, I'll go ahead and transport him. On the way to the hospital, I'll go ahead and I'll reassess the patient. I can put him on oxygen to help him out. I will reassess his level of consciousness. I will reassess his vital signs. I will reassess his pain and any therapies that I'm doing to him. Done.
10.5 minutes.
10 minutes.